Hello, hi everyone today to our broadcast for our first contouring webinar for the ACRO contouring webinar series. We are glad to have Dr. Sushil Beriwal, professor at UPMC, who's going to talk about imaging-based HDR brachytherapy for cervical cancer today. As a reminder, we sent out some pre-surveys. If everyone can fill that out, as well as the post-survey who's attendance today, we're going to hand out 5 $10 gift cards at the end of our web contouring series. So make sure you fill out your pre-survey and your post-survey to get credit for it. So I will hand it over to Dr. Beriwal, who will present today's topic.
Okay, good evening everybody. So I understand that you're at a different level of training in your program. So what I'm going to discuss is basically the concept behind 3D image-based brachytherapy for cervical cancer. I would show some of the advantages with the case-based examples and some of the clinical data which you should know as part of the learning process. And I'll show some of the contouring guidelines depending on the time, and we can focus on based on how things are moving. Okay, so all of you know, traditionally we have been prescribing the dose to the points, and the outcome data have been good, but all of us have seen unexplained morbidity and unexplained local failure, because the point-based dosimetry a lot of times doesn't correlate with the outcome, and I'll show you why that happens. Now, all of us, like in planning, we do CT-based planning for almost all sites, and the basic planning for external beam is 3D planning. But unlike external beam, the acceptance and implementation of 3D imaging and brachytherapy has lagged behind. It's unfortunate, but part of it is because of the software, the hardware, the cost, training, expertise, and the market was not as large as the external beam. And we continue to prescribe to point, although we have been using CT-based planning for external beam for almost 20 years now. The idea behind 3D brachytherapy, like any other modality in radiation oncology, is to improve local control, to decrease morbidity, and to be able to develop a model where you can predict the outcome in terms of toxicities or in terms of local control. The challenges are resource, expertise, technique, training, to be able to delineate the target, to be able to do a good planning. Now the screen in front of you shows you the ABS survey in 2007 and 2014, and in between you have survey from other continents like Canada and Australia. So if you look at 2007 survey, about half of the people in the country were still doing X-ray based planning, and even about 55% were doing CT scan. Out of those 55 people, 76% were still prescribing to the point. So even though they were doing CT based planning, they were not prescribing to the volume. Unlike that, in Canada and Australia, the acceptance of 3D planning was much higher, as you can see from the survey. But the last survey, which was done a couple of years ago, we see a significant shift in the planning. About 15% of the people are still doing X-ray based planning, but there is a rapid adoption of MR-based planning from 2% to 34%. And among people who do CT scan, about half of them still do point prescription and half of them do volume prescription. So still a lot of room for improvement to move people from X-ray based planning to CT based planning, and to move people who do CT based planning to move from point based planning to volume prescription. Now these are the same thing in the graph. You can see in 2007, 76% were prescribing to point. In 2014, still about 55% prescribed to point. Now, the idea behind point A based dosimetry is that it's a point in the paracervical triangle, and if you prescribe the dose to point, it correlates with the outcome in terms of local control and morbidity. But unfortunately, none of those things are fact. The point A doesn't correlate with the critical organ dose. Point A doesn't correlate with the prescription dose to the volume. So the basic premise based on which we prescribe to point is not valid. These are some of the applicator. In the interest of time, I would move on. So this is the example of the point-based planning. If you look at it, like you are prescribing to point A, which is 2 centimeters above lateral to the os, you have no clue of what's happening to the target. You have no clue what's happening to the critical organ. You're just looking at isodose line, a pear-shaped isodose line on a piece of paper without any correlation with the target. You prescribe to a point A and look at rectal and bladder point, which may or may not correlate with the true rectal and bladder dose. So initially several studies came out which compared the dosimetric information of point-based planning to CT-based planning. And they showed that the dose prescription to point A could lead to tumor underdosage, especially for the larger tumor like 3B disease. If you look at it here, the GTV was significantly underdosed for 3B disease. And it's very clear, if you're giving 60% of what you're prescribing to your volume, your local control would not be good. For early stage disease, the coverage was good. But for the advanced stage disease, the coverage was significantly undercovered when you prescribe to point A. Now, with the advent of this so-called MR-compatible applicator, there have been more and more use of this device in planning for brachytherapy. And in this regard, most of the initial data has come from Europe, and North America has been behind Europe in terms of taking the lead in this process. So, first of all, what's the most important advantage of 3D brachytherapy? The first important thing is to identify the correct placement of the applicator. The two most common locations where the perforation happens is the lower uterine segment and the fundus. And if you look at the data where they did the 3D imaging thinking that the patient had correct position of the applicator, the incorrect application or perforation was identified somewhere between 5 to 15% of the time. So no matter how good your dosimetry is, if you're not in the correct position, you'll not have good outcome. And this the confirmation of placement is one of the most important tool of 3D imaging. So if you look at this image on your left, you can see the applicator is through a lower uterine segment. That's the commonest location of perforation. And the reason for that happening is anteversion of the uterus. If you don't identify it, you would have it. The image on the right is after reposition of the applicator. You can see it's in the correct position. So identifying the incorrect position is very important part of the 3D brachytherapy. And no matter how good your dosimetry is on the left side, you have increased risk of complication because applicator is very close to the critical organ. One common question which comes up for the resident is, what happens when you identify this? What do you do next? And I see a variable answer from the people. Like some would say, I would take it out and wait for 2 weeks for things to heal. Some would say, oh, we have contaminated the tract, we need to do a hysterectomy. The important thing is, if you identify the perforation while you're placing it, you can reposition into it. If you identify it after that, when you have done 3D imaging, you can bring the patient back in a day or two into it. You don't need to wait for 2 weeks for tract to heal, and you don't need to do emergent hysterectomy or any kind of surgical procedure just because you had false tract. Identifying it and fixing it is the solution. And one of the important modality which helps you fix it is the ultrasound. So if you're not sure whether you're in the correct track or not, bring your radiologist who would help you in guiding the placement. Or if you have ultrasound in your own department, you could use that for having the correct placement, like in these patients. Sometimes the cavity is too distorted. Like if you look at the image on your left, it's not in the correct position, but there is no way you could get your applicator into that jigsaw track. So as long as at the level of the cervix you are in the correct position, as you can see on your image on your right, you are fine. And that's another advantage of 3D planning. You don't need to load your radioisotope all the way up to the fundus if there is no cancer there. You can just load it up at the level of the cervix, which is usually 3 centimeters or so. And you could have still good outcome without needing the need for repositioning or readjusting it. And these kind of applications are hard to adjust, but 3D imaging helps you identify it. And again, if you see the images on the left and the right on the same patient, the one on the right is into the cavity, but the one on the left you can see is going to the fundus. And that's because the 6 centimeter diameter was length was too long for the patient. So you adjust it, and the one on your right is basically with 4 centimeter diameter as tandem length. So I showed you 2 examples of lower uterine segment perforation and fundus perforation. One of the other reasons why lower uterine segment perforation can happen is in the retroverted uterus. So identifying that is important in terms of avoiding that to happen. So the second advantage, and which is the most common advantage of HDR brachytherapy using CT or MR imaging, is for the small tumor. And I can tell you from my experience in the era of chemoradiation therapy, this probably constitutes 70 to 80% of what we see. So in 70 to 80% of the situation, the tumor is small after chemo radiation therapy. You don't need to prescribe the point A because that's like overkill for the patient. So what you can do is you can decrease the 12 weight and the position so that you conform your dose to the target volume. And in doing so, you can decrease the dose to critical organ, which can decrease the morbidity. So in these patients, you will not see better local control than 2D, because 2D itself was giving high dose to the target. But you would see less morbidity, which is important part of the care of these patients. So if you look at one of the data from Canada, looking at the 2D versus 3D planning, they noticed that in small tumors, the coverage was maintained 100% or more, but they were able to reduce the dose to critical organ by 12 to 32%, which is a significant number. If you reduce the rectal dose by 30% or bladder dose by 30%, you can significantly reduce the risk of grade 2 and above morbidity without compromising local control. So this is an example. The red volume is your target volume, which by definition is high-risk CTV, and I'll describe what it means. But you see the point A is outside the high-risk CTV. The point A corresponds to 80% isodose line. So in this patient, if I would have prescribed to point A, I would have prescribed to green line, which is not needed because the target is much smaller. And in doing so, I can decrease the dose to the sigmoid, you can see, which is close by. Another example, the non-optimized plan is on your left where you prescribe to point, and the optimized plan is on the right where you prescribe to the volume. You see how close the sigmoid is to the target volume, and the target is very small, the cervix is very small. So if you prescribe to point, as you have done on the left side, you can see half of the sigmoid is getting prescription dose. And the risk of complication like sigmoid stricture and sigmoid bleeding would be extremely high in this patient. But the same patient, once you optimize the plan, you could see the dose to the sigmoid is decreased significantly. And you have 75% isodose line going to the sigmoid, but the 100% isodose line is away from the sigmoid, just touching the sigmoid. So this patient, you could, the coverage of the target volume is still 100% or above, but you're able to reduce the dose of critical organ. It's very important to being able to optimize to the target and reduce the dose to critical organ. Another example, look at point A. In this patient, the point A is in the sigmoid. It's touching the sigmoid, and the target volume is much smaller. So by prescribing to the point A, we would be hurting the patient by giving dose to the sigmoid. And by prescribing to the volume, we are able to reduce the dose to the critical organs. Another example, we see the point A in the bladder. So I've shown you multiple examples through this, like 5 minutes of different cases. You can see point A has been on the bladder, point A has been the sigmoid, point A has been nowhere related to the target volume. And this is not very uncommon in the era of chemo radiation therapy, where people have very good response to chemo radiation therapy after external beam, and the tumor shrinks significantly, the cervix shrinks significantly, that the point A dose is basically overkill. And what happens, in essence, you end up treating rectal and bladder to high dose. So in these patients, just prescribing to the volume, we are able to decrease the risk of complication. And that constitutes, I would say, 70 to 75% of what we see in the clinic. You can see in this patient, the bladder is very eccentric. So you can decrease the dwell time on the ring on one side to be able to reduce it. Again, another example of eccentric dwell time. And this concept was validated clinically by the group from Australia, where they did MR-based planning for the first fraction and ultrasound-based planning for the remaining fraction. And they compared 2D LDR to 3D SDR. And they noticed that there was no difference in local control between the two modalities. But the risk of being asymptomatic from any kind of complication was almost 25% higher with 3D versus 2D. And there was no difference in survival. So they concluded image-based SDR planning led to decrease in late radiation effects by decreasing the dose to critical organ without affecting patterns of failure and survival, for the reason which I showed you with the case-based examples. Now, the second advantage of image-based brachytherapy is dose escalation, or to be able to cover the target volume with adequate dose. In the era of chemo radiation therapy, probably this constitutes 20 to 25% of the tumor, where the response is not as good as you desire. The target is still very big in size, and if you prescribe to point A, you will be underdosing the target. And that way, we all know that if your target is not getting prescribed dose, your local control would be inferior. So in these patients, you could potentially improve the local control without increasing the risk of complication by monitoring the dose to critical organs. So this is an example. You can see that the target is very eccentric. The disease is more posterior, and if you prescribe to point-based planning, you would not get anywhere close to the target. So you were able to treat the target, monitoring the dose to rectum and bladder, and cover the target volume adequately. This is another example of we using hybrid applicator. So how do you improve the target coverage in this patient? Most of the time you have to use more than what you use with intracavitary alone. Either using interstitial implant or doing hybrid applicator like Vienna applicator. So this is one of my case showing Vienna applicator. The picture on the top is the patient having ring and we simulated as if we are treating the ring and tandem without the needle. The picture on the bottom is by adding few needles. You can see on the top that the red volume, which is the target volume, is not getting covered on the right side because tumor is very eccentric. But in the bottom picture, you can see the target volume is getting covered because we use some needles to cover it. Like this will give you an example again. You can see that the target volume is getting covered because we use some needle. We use somewhere between 2 to 6 needle on the lateral aspect of it. What the needle does is it helps you extend the isodose line by 10 to 15 millimeter laterally. So in people who have moderate response where the bulky central disease is still present, you can extend your isodose line 10 to 15 millimeter beyond point-A dose. And that way you are able to cover the disease laterally without affecting rectal bladder dose. You can see that in the example above, if I had to treat this target volume, I would have to increase the weighting so much that the rectal dose would go up. But in this case, we put some needles in, extended the isodose line laterally without affecting the rectal and bladder dose. So another example, you can see how the isodose line is extended laterally on this side and on this side. So you are able to extend the isodose line laterally to help improve the coverage. Sometimes you may not need to put the needle in if the disease is very centric. You can increase the weighting. Like in this patient, you can see the point A was slightly outside the target volume. So when we increase the weighting from the tandem, the point A got 110% of the prescription dose, but the target got 100% of the dose. And that way, we were able to increase the weighting looking at dose to the sigmoid and the bladder. So having 3D imaging gives you a comfort level of changing your dwell weight and position according to the coverage, respecting the tolerance of rectum, bladder, and sigmoid. And it's very important to have that 3D information in front of you when you're trying to make those adjustments. See another example where the point is within the target volume. The target volume is larger. You could cover it without putting the needles in by increasing the weighting from the tandem. Yeah. And when we are looking at these plans, well, you should have access to this Excel sheet which is available on RTOG website and ABS website. Basically what it does is it converts your dose per fraction to the equivalent dose at 2 gray per fraction, which all of us are used to that number. So what you do is you look at the number for each fraction, and so like in this case, 45 gray is the external beam volume. We prescribe 6 times 5. So the bladder 2 cc got 5.5, rectal 2 cc 2.7, sigmoid 3.5, and target 5.2. This was a patient without the needle. You can see your D90 for the target is 77.18 gray, but the bladder is getting 90 gray. But in the same patient, when we simulated by putting the needles in, the D90 for the target is 90 gray, and the bladder is getting 88 gray. So you are able to improve the dose by 20 gray without affecting the critical organ dosimetry, which is a significant improvement in the therapeutic ratio by increasing the dose. And we were able to do it by putting the needles in. So it's important to monitor the dose for fraction to fraction and convert that to equivalent dose and make sure target gets what you want. Normally we aim for a target dose of between 80 to 90 gray depending on stage of disease, response to the treatment, and the amount of disease visible at the time of brachytherapy and the critical organ dosimetry. So for good responder, we try to aim 80 to 85 gray. So I prescribe 5.5 times 5. For poor responder, we aim 85 to 90 gray. So we prescribe 6 times 5. And we try to optimize the plan so the D90 for each fraction is 100% or more. Similar concept like prostate. When you do D90, you want D90 to be prescription dose and above. So we want D90 to be prescription dose and above, and D2cc of rectum, bladder, and sigmoid, and I'll talk and show you the data. We have scaled down now. In the past, we used to take it 85 to 90 gray for the bladder. We try to limit close to 80 gray. And for the rectum and sigmoid, D2cc less than 70 gray. Preferably 65 and below, but at least less than 70 gray. This is our own data for about 125 patients. You can see our mean D90 was 83 gray. The 0.8 dose was lower than D90 dose because of the reason I explained that majority of people that were a good responder, you did not need to give that high dose to the 0.8. And D2cc for the bladder and rectum and sigmoid were within the acceptable limit. And we reported our outcome and we showed close to 90% local control. We did notice higher recurrence rate in adenocarcinoma. So our philosophy now in adenocarcinoma is to give 85 and above whenever it is feasible. And the grade 3 complication was less than 5%, 2% or so. So significant therapeutic improvement in the sense that local control is close to 90% and grade 3 complication less than 5%. This is summary of all the large published data. The big one is from Australia using combination of MRI and ultrasound. Local control 88%. The Vienna series 95%. Our own series 92%. The French data which I'll show you 79%. The Polish data, the largest data with CT-based planning 90%. The Paris data using MR-based planning. So you can see consistently that the local regional control are close to 85 to 90%. The retro embrace is combination of data from multiple institutions in Europe and Asia, and again local control 91%. So the local control, which we used to quote around 80% or 75%, has gone up close to 90% now. The survival is in this range of 60 to 70%. And if you look at grade 3 complication, you can see consistent in most of the series, it's 5% or around, which is a significant change in what you compare with the historical data which is available. But there's a difference in approach, like the group in Australia hardly used interstitial, but the group in Vienna used interstitial 44% of the time. In our own series of 128 patients, we use Vienna applicator about 7% of the time. So it varies from practice to practice. But no matter what technique you use, you are able to optimize the local control and decrease the morbidity. We also looked at what is the value of imaging in terms of predicting the response. So we identified about 84 patients, contoured the volume of disease pre-MRI and at the time of first brachytherapy. And we noticed that the response to chemoradiation therapy predicts for outcome also. If their GTV at the time of brachytherapy was more than 7.5 cc, the local control was 75% versus 97% if it is less than 7.5 cc. And so probably these are the subset of people where there is some value of dose escalation, doing something more additional like chemotherapy or surgery, we don't know. But we are able to identify the poor responder and predict the outcome in those patients. So the image-based brachytherapy, the MRI allows for assessment of tumor regression and helps you prognosticate the patient. This is the French data which all of you should know. It's the only, I would say, multi-institution prospective data other than Embrace, which is now starting to publish the data, but they have not published the outcome, but more like early feasibility one. So this is the French data, and I would like you to focus on group 3, which is the chemoradiation group. Group 1 and group 2 had different management plan. So if you look at it, with the 3D versus 2D, the local regional control and the relapse-free survival were not, they were very comparable. But if you look at the toxicity, the grade 3 complication was 22.7% with the 2D and versus 2.6% with the 3D. About 20% improvement in grade 3 complication. And in grade 2 complication, about 10% improvement. Now, if you look at the local regional control, I mean, the numbers were 4 or 5% difference, slightly better with 3D. But overall, the major advantage was a decrease in the morbidity, which is significantly different. These were all CT-based plan, multi-institution, and they one of the reasons you could make an argument that local regional control were not as good as you would think likely to be, but the doses delivered in the trial were on the lower side, and that's how it is practiced in France. But overall, when you compare with the traditional 2D plan, it was still better with the 3D plan, and more importantly, 20% improvement in grade 3 complication. I mean, if you have any modality which causes 20% improvement in grade 3 complication, there is no reason why you should not be doing it. I mean, when we look at 3D versus IMRT for prostate, we do not have that difference in the morbidity. The difference in the morbidity is 3%, 4%. Like if you add proton on top of it, we hardly see any difference in morbidity. But here you have a modality which anybody in any department can use it. Just CT-based planning, not state-of-the-art MR-based planning, 20% improvement in grade 3 morbidity. I mean, if you have a modality which can improve outcomes so significant, there is no reason for us to do 2D-based planning. Now, I'll touch in brief some of the data on the organ at risk in the same notion that the traditional point-based plan tend to underestimate the dose of rectum and bladder. Like these were comparing 2D plan to 3D plan and looking at the dose of rectum and bladder. So whatever dose we were thinking we are prescribing rectum and bladder, in reality the dose is 1 to 2 times more than what we are prescribing. So it was under-assessing the dose to the critical organ because the point-based planning is not a good modality to look at critical organ dose. And in practice, what we look at is dose to 0.1 cc, 2 cc, and 1 cc dose to the critical organ. And what people have shown is that 2 cc dose to bladder, rectum, and sigmoid is a good predictor of late toxicity, both in terms of patient-reported outcome and sigmoidoscopy. So if you look at it, if your D2 cc dose is 75 versus 69, the risk of sigmoidoscopy-related grade 3 complication is significantly lower. Same thing, the symptomatic rectal bleeding is significantly lower. So if you look at this number, we should aim for the numbers which are on the right side. So D2 cc preferably less than 70 gray or preferably less than 65 gray, if you can do it. There is a good correlation of 1 cc dose to 2 cc dose to 0.1 cc dose. But to be consistent, maybe reporting 2 cc dose and monitoring 2 cc dose is sufficient. So we try to aim a dose less than 70 gray, preferably less than 65 gray feasible. Now less than 65 gray sometimes not feasible, and that's where in Vienna group they use needles to help decrease the dose of critical organ. But 70 gray is feasible most of the time if you are cognizant of the dose to your critical organ. And again, the risk of 5% grade 2 and above complication is 5% if you have dose of 67. It goes to 10% if you have 78. They did not find any bladder correlate initially in this Vienna data, but I'll show you some other data where they find some correlate. So this is the retro-embrace data, which has been presented multiple times. So look at the correlation of outcome with DVH. If your D90 is less than 85 gray to the target, for stage 1 and stage 2 disease, there is not much of a difference when it is more than 85 or less than 85. But for stage 3 disease, you see there is a 15% improvement in local control when your D90 is less than 85 versus more than 85. So there is room for dose escalation for stage 3 disease. For stage 1 and stage 2 disease, the number look very comparable. If you look at risk of grade 2 bleeding, again, the risk is 30% if it is more than 70 gray and 15% when it is 70 gray or less. So the risk of grade 2 complication goes down significantly if your D2cc is less than 70 gray. And they did find some correlation with the bladder dose. D2cc, if it is more than 80 gray, the risk of grade 2 morbidity was 40%, which went down to 20%. So this is retrospective data from multiple institutions which pulled their data and looked at the outcome. But they are validating this data set in prospective EMBRACE study. And as part of the EMBRACE 2, which is an ongoing study we just started this year, what they are doing is they are trying to achieve these goals. So D90 or more than 85 gray for stage 3 disease, and D2cc less than 80 gray and less than 65 gray if feasible. And that's why the institution which participated in study should be able to use Vienna applicator or Utrecht applicator because you would end up using that applicator almost 40 to 50% of the time to meet these constraints. Otherwise, to be able to meet the tight constraint for the rectum and the bladder becomes hard when you're doing dose escalation. So this is their retrospective data for EMBRACE, which is again showing correlation of outcome with the DVH, which is important and which lets us know that there is there is, I mean, if you give the dose, you will see the effect either in terms of local control or in terms of morbidity. The another important thing they found in the EMBRACE study was the vaginal toxicity was a function of rectovaginal reference dose. And it's important not to load the vaginal applicator with a too high rating, because when you do 3D planning, sometimes you get, if you don't look at the local dose, you may look at the deviation, it may look good, but the vaginal dose may be significantly higher. So it's important, and it's part of the current ICRU data, the guideline which came out this year, which talks about looking at the rectovaginal reference point dose, keeping it 65 and below to keep grade 2 rectal complication, grade 2 vaginal complication less than 20%. So it's basically the same rectal point which we used in the past for rectal dose. This now they're using for as a reference point for vaginal dose. So switching gear, talking about the contouring guideline, if you have MRI in the department, use T2 weighted sequence, use high signal intensity and gray zone to identify your volume. Now, to expedite the process, at our own center, we use tube sequence, which takes 5 minutes to acquire, has 1 millimeter slice thickness. You do lose some signal, but it is easy on the patient in terms of time required to acquire the images. For some of the departments which have got Siemens machine, they can use space sequence, which is a T2 tube counterpart for the GE equipment. And you prescribe the dose to high-risk CTV, which by definition is entire cervix plus any residual palpable or visible disease on the imaging. So if somebody has complete imaging response at the time of brachytherapy, at minimum you will treat the cervix. So the minimum volume which you treat is cervix. And on top of that, if there is anything visible on imaging or clinical exam, you add on top of that. So your high-risk CTV by definition is cervix plus anything residual disease seen on the imaging or clinical exam. You don't need to give any margin because it's brachytherapy, the applicator moves with the tumor. You don't, the JCASTRO defines IRCTV, but you don't need to worry about it. I wouldn't focus too much on IRCTV. It's a concept used in some centers in Europe, especially France, where they prescribe to IRCTV. But in practical life, I would ignore it at this point and focus only on HRCTV. You don't need to worry too much about IRCTV. So this is what the white volume is the GTV, the yellow volume is the HRCTV, and the orange volume is the IRCTV with the margin. Now, when you look at the sagittal view, you can see the yellow volume has a conical end, which basically corresponds to the conical shape of the cervix. So unless patient has extension of disease to the endometrium, you don't need to target or cover endometrium in your HRCTV volume. And these are some of the examples. If patient has complete response, cervix is the HRCTV. If patient has partial response, then it's residual disease. So the image on the bottom part is the one where you need more than Vienna applicator. You would need something like template-based brachytherapy. Or now the Vienna group has designed another applicator where you can extend the isodose line by putting more needles in. So the first one you could treat with the ring and tandem or tandem and OH by itself. The second one you could treat with Vienna applicator. The third one you may or may not be able to treat with Vienna applicator, but the last one you would not be able to treat it because you will not be able to extend your isodose line that far laterally to be able to cover with your. So you need template-based brachytherapy in these patients. This is the formula which I showed you, the equivalent dose. We use the alpha beta value of 10 for the tumor and 3 for the normal tissue. And you basically convert your dose per fraction to equivalent dose to 2 given fraction. This formula doesn't take into account the total treatment time, which we at this time we presume patients who are completing in 7 to 8 weeks time. But that being said, if the treatment gets prolonged, then the numbers may not be the same number. And this is one of the examples similar to what I showed you before. And in the new ICRU guideline, they ask you to even look at 0.1 cc dose, 2 cc dose, along with the D90 for the HRCTV and the total dose to HRCTV, GTV, and the other points. It's a full manual which is available online. You can get it online. With both European group and the North American group combined together to revise the guideline. The last one was ICRU 38, so there's a new guideline which has come out. This is just showing you an example. This is pre-treatment MRI and this is post-treatment MRI. You can see how good the regression is and how your volumes are changing. Another example of how the volumes are changing. For critical organ, you contour the entire organ because people have looked at contouring the entire organ versus contouring the wall. And for 0.1, 1 and 2 cc, the doses are same. It's too cumbersome and tedious to contour the wall. So you can just contour the entire organ and look at 0.1, 1 cc, 2 cc. So you can see you can contour the entire bladder or entire rectum. And it's important for brachytherapy that unlike external beam, when you do the contouring, your denominator has to be good and consistent because you're comparing a ratio. When you say your V70 for the prostate patients for the rectum should be less than 15%, your denominator of rectum should be defined the same way in each patient for you to be comparing it. With brachytherapy, the denominator is not as important as long as you contour the target volume and the critical organ close to each other adequately. So, like if I don't contour this part of the sigmoid, it's okay, it's away from the target and away from the applicator. But if I don't contour this, I would under-assess the dose. And since we are looking at absolute dose, the denominator is not of that significance. We are looking at 1 cc, 2 cc absolute dose, not the percentage dose. So if I don't contour the rectum here, it would not matter much because that's not in the high dose region. But if you don't contour this area or this area, that will not be reflecting correct dose for the critical organ. So that's major difference between assessing the dose for brachytherapy, where you look at highest dose or high dose volume to a small area, unlike external view where you look at the percentage dose. So like if you're looking at lung cancer patient, if you don't define both lungs minus GTV or PTV the same way in each patient, your denominator would be different and you would not be able to compare patient 1 to patient 2. So this is the example of like this. I just, one more part I want to emphasize, the argument of contouring and planning for each fraction. This is 5 fractions on the same patient. This is fraction number 1, 2, 3, 4, and 5. And I want you to focus on the position of the sigmoid. See the position of sigmoid in this fraction 1 versus fraction 2 versus fraction 3, 4, and 5. So sigmoid is the most mobile of the critical organ and it changes the position significantly. So it's very important to plan fraction to fraction, otherwise you will not be able to account for the dosimetry of the critical organ. Now out of the 3 organs, sigmoid is more forgiving also because when you calculate D2cc dose, you calculate for the worst possible scenario, presuming same part of the sigmoid is getting high dose at each fraction. But if the scenario is like this, you realize that D2cc dose with sigmoid is the worst case scenario. In reality, the part of the sigmoid is not getting the same fraction and same dose at each fraction. So you have more leverage and more room to increase the dose to the sigmoid without compromising the dose to target volume. In practice, that happens, but not very infrequently, where you have to make that determination or make that call. So MRI is not universally available, and we need to do repeat imaging to account for the critical organ dosimetry. So can we substitute CT scan with the MRI? And if you look at the data, that yes, it could be substituted provided you know the limitation and you know the pros and cons of it. The initial study of comparing MRI to CT consistently showed that the volumes of target volumes are higher on the CT than MR. And the reason is the lateral width and the superior extent is it's hard to estimate on the CT scan. The critical organ doses are, and the critical organ contouring is more or less consistent. But like in this study, if you look at it, if you use MR-based plan and do CT-based contouring, there is about 10% difference in the dose because of target volume being larger on the CT. Right, these are some of the examples where it's hard to know where the lateral edge of the tumor is. And in European data, there is more consistency and less inter-observer variability with MRI. But when we did the same study in US, it's published, it's in Red Journal, right? And there was more consistency with the CT scan than with the MRI, probably because in US people, the practicing radiation oncologists were more used to CT-based planning, while in Europe they're more used to MR-based planning. And it was seen the highest area of inconsistency was when the parameter was involved, where we didn't know where to end and where not to end. So one approach is to do MR for the first fraction and CT for subsequent fraction. And like this patient, this is the MRI before treatment, this is the MRI at first fraction. So you do the planning with the first fraction. And then for contouring, the important step is start your contouring at the superior level of the ring or just inferior to the vaginal extension if it is present. If parametric ridge is present, brachytherapy contour 1 to 2 centimeters from the edge of the cervix. and parameter contour at the level of the ring and extend up to the height of the cervix, not beyond that. So you start at the level of the ring, just on top of the ring. Keep contouring. This is MRI on the left, CT on the right. You can see MRI on the left and CT on the right. So you can see out here, if you did not have MRI, you would be probably contouring more on the lateral side. So this is the sagittal view, which is very important and very critical when you are doing the contouring, because it helps you identify the posterior edge, helps you identify the anterior edge, and you can create a conical center. So this is CT, MR-based planning, and the same patient CT-based planning. If you have the information from MR, you could probably reproduce the contouring on CT with reasonable accuracy and consistency, with a difference in volume in few cc only. So having MR information helps you contour on the CT also. So here you can see the same patient, the example of the planning. And initially we did a study where we used the hybrid approach, and we showed that the target volume is consistent, the critical volume is consistent with published data, because we were using MRI-based planning for the first fraction in terms of defining the CTV. Now we have moved to MR-based planning for all fractions, because we have optimized our planning for the MR. We have optimized our planning for the time required for the MR imaging. So we try to do MRI planning for each fraction unless patient is claustrophobic or there are other contraindications during the MRI. Now this is the consensus guideline which is available online. You can practice on this guideline, and basically it shows a comparison of CT and MR-based brachytherapy, and you will see like how different this is in comparison to European data. Then we have published a similar concept of image-based brachytherapy for vaginal cancer and image-based brachytherapy for endometrial cancer. You can pull those data to show that how the integration of 3D imaging have really improved the outcome in comparison to historical control. Like the local control in this series is close to 90%, and the grade 3 complication is 5% or lower. The local control in this series is close to 90% with very low grade 3 complication, emphasizing the importance of knowing where you prescribe, knowing what is the target volume, knowing what your critical organ is. So it's time for us to move from point-based planning to image-based planning, like what we do for SBRT and EBRT every day in our day-to-day practice. It gives you good estimation of dose to critical organ and good dose to the target volume. It helps you improve the target volume and reduce the dose to critical organ. And the outcome data is showing excellent local control and decreased mortality. We need to get more outcome data from prospective studies which are ongoing, and improve some of the concepts of target contouring and variability in terms of interfraction for brachytherapy. Thank you.
Thank you for that great lecture. So just a quick question. So how do you determine, or how do you place interstitial needles during the time of brachytherapy? Do you kind of pre-plan it, or do you actually do it during the treatment?
So let me tell you, there are two types of interstitial we do. One is a template based, the other is a Vienna applicator. So normally, let me talk about the Vienna applicator first. So all these patients get 5 fractions of brachytherapy with the dose per fraction being 5.5 to 6 gray. So sometimes what would happen is, for the first fraction I would do straightforward intracavity brachytherapy with ring and tandem in place and look at my plan. And if I look at the plan and I feel that this patient would benefit from needle placement to help reduce the dose of critical organ or to improve the coverage, then for the remaining 4 fraction I would use the hybrid applicator. And what I do is the MRI which I have done for the first fraction, I use that MRI to decide how many needles I would use and what would be the position of those needles and what would be the depth of insertion of those needles. So that first fraction MRI gives me an idea about number of needles, the position of the needles, and the depth of the needle. Then when we bring back the patient for the second fraction, I use that information in inserting the needles in those positions, at those depth, at those location, and then do a CT scan and MRI based planning and use the same information for each of the remaining 3 fractions. So that way only I've delivered 20% of the dose without the needle, but the rest 80% goes with the needle in place. And we have shown feasibility of this approach and excellent dosimetry. Now what the Vienna group does is, since they place applicator only twice and give 2 fractions each time, they do a dummy plan prior to the first insertion and decide based on the dummy plan where to put the needles in and how many needles to do, and then do the plan. So both approaches are feasible as long as you know what your plan of care is and how you're going to implement it.
If anyone has any other questions, we'll take questions right now. You just go to the bottom of your box and you just ask questions as necessary. The other question I had was, what normal fractionations do you use for your cervix cancers? I know some of us don't treat as much cervical cancers.
So just to butt in for everyone, when you submit questions in chat, make sure that you select it for send questions to staff under the drop-down menu.
So like our fractionation schedule is between 5.5 to 6 gray times 5. So our normal fractionation is 5 times 5, which after 45 gray comes out to about 80 gray, and our D90 dose is somewhere around 80 to 85 gray because the coverage is between 100 to 110%. But if the patient has adenocarcinoma or the response is not good, then we push the dose to 6 times 5, which in terms of equivalent dose comes to 84 gray, but the coverage is somewhere around 6 to 6.5 gray, so it comes somewhere between 85 to 90 gray. So we prescribe a dose of 80 to 90 gray, with 80 to 85 for most patients and 85 to 90 for poor responder or adenocarcinoma. So the dose per fraction is 5.5 to 6 times 5. Now when the Vienna group does 7 times 4, that comes to a similar 84 gray. So but the commonest fractionation used in North America is 5.5 to 6 times 5 fractions. Does it answer your question?
Oh, so the other question is, can you speak about the timing of brachytherapy in relation to concurrent chemo-RT?
So what we do is like we start brachytherapy in 4th or 5th week of radiation, and they get once a week brachytherapy as long as they're on external beam. But we don't do brachytherapy and chemotherapy on the same day. And once they've complete external beam, we do twice a week brachytherapy to complete the treatment in 7 to 8 weeks time. So if they have first brachy in week 4, so week 4 and week 5 and week 6 will be once a week brachy, and week 7 will be twice, and they're done. Now the data from Embrace, which was presented at ABS, showed somewhat better outcome if the treatment was done within 7 weeks instead of within 8 weeks. But that could be a factor of, you might have done that kind of approach for people who have good response or something like that. But overall, we try to complete the treatment within 8 weeks, so that if we start brachytherapy in 4th or 5th week of radiation, we are done in 7 to 8 weeks of radiation. Chemotherapy is in the first 5 or 6 weeks only. It is not done on the days of brachytherapy. And if the patient does well, we try to do stretch chemotherapy to 6. If they have significant side effect, we try to stop at 5. So between 5 to 6 chemotherapy in weekly fashion. There's data to suggest if they get 4 or less chemo, then probably there is inferior outcome. And again, it could be reflection of disease, it could be reflection of performance status. So there are other factors which come into play. But we try to give a minimum of 5 and a maximum of 6 chemotherapy if the patient tolerates well.
Could you speak on the pros and cons of tandem and ring versus tandem and ovoid brachytherapy? And then also, like, I know Vienna applicator you touched on already a little bit.
So practice pattern have shown significant change. In the past, tandem ovoid used to be the most common applicator, but now tandem ring is the most common applicator. Partly because it's easier to use, more reproducible, and convenience. But there are pros and cons of both approach. When you use a ring applicator, the source is about 7 millimeter from the surface of the vagina. So the vaginal surface dose is higher with the ring applicator, and the lateral protrusion of isodose line is slightly less. When you use the ovoids, the center of the source is somewhere between 0.75 to 1 to 1.5 centimeter, depending on the size of the ovoid from the surface. So following the inverse square law, the surface dose to the vagina is less with the ovoid, and you have better isodose line, a better depth dose laterally. So technically, isodose lines are more laterally projecting with their ovoids and less surface dose. But in clinically, people have not reported any difference in outcome. But you may notice slightly more vaginal toxicity with ring and tandem, but that has not been compared and reported. So that being said, it's a matter of convenience, it's a matter of training, it's a matter of comfort level. We have both the applicator. More commonly, we use ring and tandem, but once in a while, for a different kind of anatomy, especially, I may use tandem and ovoids also. Sometimes for narrow vagina, it's easier to insert the ovoids because ovoids are in split fashion. Ring is not in split fashion. It's hard to insert it. As far as hybrid applicator is concerned, they are available with ring and tandem also, and tandem and ovoid also. The one with the tandem and ring is called Vienna applicator. The one with tandem and ovoid is called Utrecht, which was designed in Netherlands. And both do the same job. They basically extend the isodose line laterally by 10 to 15 millimeter. So it's not that one is better than the other. The outcome data for both look very similar. It's based on your comfort level. If you're used to tandem and ovoid, then you may use Utrecht applicator for hybrid. If you're used to tandem and ring like us, then we would use Vienna applicator. But when you use the Vienna applicator or Utrecht applicator, you need to realize that loading from the needle is very small. The ratio between tandem and ring is 1:10 or 1:5. So if your tandem weighting is 1, your ring weighting is 0.1. You cannot use too high a weighting for the needle. That increases the surface dose and it can increase the risk of toxicity. So you have to be very careful when you optimize with the needle in place in terms of a local dose and in terms of how much weighting you put it in. And I mean, you don't want to extend your isodose line by 2 centimeters by using the needle. That's not going to happen. That will increase the local dose and it can increase necrosis or the risk of complication of ureteric complication, things like that.
All right. Thank you, Dr. Beriwal, for your time today. We have no more questions, but we appreciate your time and thank you for this great lecture. As a reminder, our next lecture will be Dr. Gia, who's going to present a spinal SBRT. For those who attended, please fill out the post surveys and for the gift card. Thank you. Have a great day, everyone.
Good. Just one last point. If any one of you have any questions, feel free to email me. I'm accessible by email, and I would be more than willing to answer any one of your residents have any questions. Like if you're not doing too many of these in your program, feel free to email me if you have any questions or concerns. And thank you all for staying that late for being part of this presentation. Thank you.
Thank you.